Now, we move on to aminoglycosides, antibiotic. What are aminoglycoside antibiotics? These are a group of natural and semi-synthetic antibiotics which contain amino sugars in glycolidic acid linkage. What are the classification of aminoglycosides? The classification of aminoglycosides are based on antibacterial spectrum. First in our list is the narrow spectrum. Streptomycin and dihydrostreptomycin mainly active against aerobic gram-negative bacteria, such as E. coli, Salmonella, Pasteurella species, and Brucella species, and also against Staphylococci, Actinomyces bovis, and Leptospira species. Mycobacterium tuberculosis is sensitive to streptomycin. Next in our list is the extended spectrum. Neomycin, Pharmamycin, Aparamycin, and Gentamicin. They have broader spectra than streptomycin and effective against aerobic gram-negative bacteria as well as against several gram-positive bacteria. They are clinically most useful against gram-negative infections caused by E. coli, Salmonella, Klebsiella, and Enterobacter. Third in our list for the classification of aminoglycosides are the broad spectrum. Example of this is the gentamicin, tobramycin, amikacin, sisomycin, and nittelmycin. They are highly effective against wide variety of aerobic bacteria including Pseudomonas aeruginosa. Gentamicin is more potent than streptomycin, but it is ineffective against Mycobacterium tuberculosis. Amikacin and nittelmycin are resistant to bacterial aminoglycoside inactivating enzyme and therefore have widest spectrum of activity including against organisms resistant to other aminoglycosides. Lastly, we have the miscellaneous aminoglycosides. Example of this are the Aparamycin and the Spectinomycin. These are drugs that are structurally somewhat different from typical aminoglycosides but have similar antibacterial spectra and mechanism of action. In our next slide, we have the sources of aminoglycosides antibiotics. For the streptomycin, we have the Streptomyces griseus, and for our neomycin, we have the Streptomyces fraday, and for the kanamycin, we have the Streptomyces kanamyceticus, and for our gentamicin, we have the Micromonospora purpurea, and for our tobramycin, we have the S. tenebrarius, and for the amikacin, we have the semi-synthetic derivative of kanamycin, and for our sisomycin, we have the Micromonospora inioyensis, and for our nittelmycin, we have the semi-synthetic derivative of sisomycin, and lastly for our pharmacettin is the S. lavandulae. Moving on to the next slide, what are the common properties of aminoglycosides? First, we have all are used as sulfate salts that are highly water soluble and the solutions are stable. Second is we have none is absorbed after oral administration as they are polycations. Third is we have none penetrate the brain or the CSF. Fourth is we have all are rapidly excreted and changed through normal kidney or by glomerular filtration. Fifth is we have they are exclusively used in the treatment of gram-negative bacterial infections. Sixth is we have all act by interference with the protein synthesis in susceptible bacteria. Seventh, we have they are bactericidal and more active at alkaline pH. Eighth is we have partial cross-resistance may be seen among them. Ninth is we have they have relatively narrow margin of safety. And lastly, for the 10th, all share common toxicities such as ototoxicity and nephrotoxicity. Now, moving on to the mechanisms of action of aminoglycosides antibiotics. All the aminoglycoside antibiotics inhibit bacterial protein synthesis, They exert a fast bactericidal action. The antibiotics diffuse across the bacterial membrane and bind to the ribosomal subunits. Streptomycin binds with 30S subunits, where others bind to the additional sites on 50S ribosomal subunit as well as 30S to 50S interface. Moving on to the pharmacokinetics of aminoglycosides antibiotics, aminoglycosides are poorly or not absorbed from the GI tract, but absorption from intramuscular site is rapid and complete. They distribute only into the extracellular fluid with minimum penetration to the most of the tissues except the kidney and the endolymph of the internal ear. They show low tendency to bind with the plasma proteins and effective levels are not reached in the CSF or milk. These antibiotics are not metabolized in the body of the animals and are mainly eliminated on change in the urine by glomerular filtration. Now, we are in the clinical uses of aminoglycoside antibiotics. Aminoglycosides are commonly used in several and local systemic infections caused by susceptible aerobic bacteria. First is we have the streptomycin. Streptomycin is widely used for the treatment of bovine streptococcal and staphylococcal mastitis, pustulosis, and E. coli infection, causing mastitis, metritis, enteritis, and septicemia in all species, leptospirosis, tuberculosis, and lastly, vibriosis. Second is we have the gentamicin. It is parenterally used in the treatment of gram-negative septicemia, urinary tract, GI tract, respiratory tract, and topically in eye and ear infections. Third is we have the Aparamycin. It is rarely used systematically because of the ototoxicity and nephrotoxicity, but used for the treatment of enteritis and topically for otitis externa in dogs. Lastly, we have the nettlemycin. Is resistant to the bacterial aminoglycoside inactivating enzyme and thus effective against gentamicin resistant strain. Following the clinical uses is we have the adverse reaction and toxicity of aminoglycoside antibiotics. The aminoglycoside produce toxic effects which are common to all, but the relative intensity may differ. The main toxicities are first the ototoxicity. This is the most important dose and duration of the treatment-related adverse effect. The ototoxicity involves progressive and irreversible damage to and destruction of the sensory cells in the cochlea and vestibular apparatus of the internal ear. Second is we have the nephrotoxicity. It is due to the damage of the kidney tubules and this is more common in the patient with pre-existing kidney diseases. Renal damage can be reversed by immediate discontinuation of the drugs. Following that is we have the neuromuscular blockade. High doses of aminoglycosides may cause neuromuscular blockade due to the chelation of calcium and reduction of acetylcholine release from the motor nerve endings by aminoglycosides, resulting in skeletal muscle paralysis and respiratory arrest, which may even lead to death. Neomycin and streptomycin are more prone to cause this toxic effect than canyamycin, gentamicin, or amikacin. Tobramycin is least toxic in this respect. The blockade can be partially antagonized by intravenous calcium gluconate and neostigmine. Neuromuscular blockers should not be used cautiously in animals receiving aminoglycoside antibiotics. Following that, we have the hypersensitivity reactions, contact dermatitis, and sometimes allergic reaction, particularly to the streptomycin, is common. Lastly, we have the rapid intravenous injection. At high doses may cause CNS disturbance, even convulsions, respiratory arrest, fall in blood pressure, collapse, and even death. Now, in these slides, what are the contraindications and precautions of aminoglycoside antibiotic usage to be avoided during pregnancy, along fetal toxicity, along with other ototoxic drugs, and with other nephrotoxic drugs? Neomycin is contraindicated in animals prone to post-parturient hypocalcemia. Now, in this slide, we have the dosage of aminoglycosides. For streptomycin and dihydrostreptomycin, we have oral intake for 20 mg per kilogram 2 to 3 times a day, and for intramuscular, 8 to 12 mg per kilogram twice a day. And for the intramammary route of administration, we have at 100 mg per quarter in dry cows. And for gentamicin, we have 3 to 6 mg per kilogram intramuscularly or subcutaneous 2 to 3 times daily. For kanamycin, we have 12 to 15 mg per kilogram intramuscularly or subcutaneous twice a day. For amikacin, we have 5 to 7.5 mg per kilogram intramuscularly or subcutaneous once or twice daily. For the nitomycin, we have 3 to 6 mg per kilogram or intramuscularly or subcutaneous once or twice daily. Lastly, for the neomycin, we have the oral dosage of 20 mg per kilogram thrice a day, and for intramammary at 0.5 to 1 gram per quarter daily. Following the dosages of aminoglycosides, we have the drug withdrawal time for aminoglycoside antibiotics. For oral dosing, we have 20 to 30 days. For parenteral dosing, we have 100 to 200 days and 2 to 3 days after intramammary administration. Usually not approved for use in food animals. Lastly, we will discuss the miscellaneous aminoglycosides. First, we have the Spectinomycin, an aminocyclitol antibiotic produced by Streptomyces spectabilis. It is active against several gram-positive organisms, a wide range of gram-negative bacteria and mycoplasma species. It inhibits the protein synthesis in these organisms by binding with 30S ribosomes and produce a bacteriostatic rather than bactericidal effect. It is poorly absorbed from GI tract but rapidly absorbed after intramuscular administration. The antibiotic is mainly used in the treatment of CRD and fowl cholera in poultry, cholecobacillosis in pigs and poultry, and E. coli mastitis in cows. The dose for this drug is 20 milligrams per kilogram twice daily orally and intramuscularly at 5 to 10 milligrams per kilogram twice daily. Withdrawal periods for pigs is 3 weeks. Next, we have the Aparamycin. It is a bactericidal antibiotic mainly used to control gram-negative infections, especially E. coli and Salmonella infection in cows and piglets. It is also active against Bruchus, Klebsiella, Treponema, and Mycoplasma species. It is not absorbed orally but rapidly absorbed parenterally. The drug is contraindicated in cats because of its severe toxic action, but it can be given safely to other animals. It is used in the treatment of colibacillosis and salmonellosis in cows and piglets. The dose of this drug is 20 to 40 milligrams per kilogram orally and once daily for 5 days for enteric infections, and parenterally 20 milligrams per kilogram twice daily, and the withdrawal period after oral use in cows and pigs is 4 weeks. The last that I will discuss is the tetracyclines. These are a group of natural and semi-synthetic antibiotics having nucleus of 4 cyclic rings. These are all obtained from soil actinomyces and have nearly similar antimicrobial activity. All are crystalline yellow powder, slightly water-soluble, but their hydrochloride salts are more soluble and are used. It is contrast from penicillin G and streptomycin in being orally active and broad-spectrum antibiotics. So what are the classification of tetracyclines? These are classified based on sources. We have the natural tetracyclines. This includes the chlortetracycline from Streptomyces aureofaciens, and we have the Oxytetracycline from S. rimosus, and the dimethyl chlortetracycline or demeclocycline. It is from a mutant strain of S. aureofaciens. Next is we have the semisynthetic tetracyclines. Example of this is the tetracycline, metacycline, rolytetracycline, limecycline, doxycycline, and minocycline. The tetracycline is also classified based on the duration of action. We have the short-acting. Example of these are the tetracycline, oxytetracycline, and chlortetracycline. The intermediate-acting, the demeclocycline, and the metacycline. Lastly, we have the long-acting tetracyclines. These are the doxycycline and the minocycline. Moving on to the next slide, we have the antibacterial spectrum. All tetracyclines are broad-spectrum antibiotics and are practically inhibit all types of pathogenic microorganisms except mycobacteria, fungi, and viruses. Tetracyclines are active against both aerobic and anaerobic gram-positive and gram-negative bacteria, such as Mycoplasma, Rickettsia, Chlamydia, and even some protozoa like Babesia, Filaria, Anaplasma, Coccidia, and Entamoeba. Some strains of E. coli, Klebsiella, Proteus, Pseudomonas aeruginosa, and Corynebacterium species are frequently resistant to tetracyclines. Moving on to the mechanism of actions of tetracycline. The tetracyclines are primarily bacteriostatic but exert bactericidal effect at higher doses. Therefore, a responsive host defense system is essential for their successful use. They inhibit the bacterial protein synthesis by preferential binding with a 30S ribosome in susceptible organisms by preventing the attachment of amino acid acyl tRNA to the receptor site of mRNA ribosome complex. As a result, peptide chain fails to get elongated. Tetracyclines concentrate within the susceptible bacterial cells either by a carrier-mediated active process or by diffusion through porine channels to produce its action. Doxycycline and minocycline have greatest lipid solubility and enter bacteria by passive diffusion, also which make them more potent. The selective toxicity of tetracycline for the microbes is due to the absence of carrier for active transport of tetracycline in the host cells and less sensitiveness of host cell protein synthesizing apparatus. Microbial resistance to tetracycline is mainly due to decreased penetration of the drug into the previously susceptible organisms. Moving on to the pharmacokinetics of tetracycline. Tetracyclines are administered orally, parenterally, mostly intramuscular and intravenously, and also topically. Following oral administration in carnivores, the drugs are absorbed rapidly from GIT, reach peak plasma concentration within 2 to 4 hours, which persists for 6 to 8 hours. Milk and milk products, calcium, magnesium, iron or iron preparations, and antacids interfere with the absorption of tetracycline in the GI tract due to chelation. Some drugs also undergo enterohepatic cycling. Tetracyclines should not be administered orally to ruminants as they are poorly absorbed and cause disruption of ruminal microflora. In veterinary medicine, especially buffered tetracycline solution, are most commonly administered by intramuscular and sometimes intravenous routes. Intramuscular dosage gives peak blood levels after 2 hours and maintained for 12 to 24 hours. Oily preparations used for subcutaneous administration in poultry should not be administered parenterally to mammals. Tetracyclines are widely and extensively distributed to almost all the body tissues and fluids, particularly after parenteral administration. These drugs undergo chelation with calcium and are deposited irreversibly in growing bones and teeth in young animals. Doxycycline and minocycline readily penetrate tissues and also CSF. Protein binding varies from 30% Oxytetracycline to 90% Doxycycline. Tetracyclines undergo limited metabolism in domestic animals except doxycycline and minocycline. They are chiefly excreted by kidney via glomerular filtration and also excreted unchanged in feces directly or through bile. Most tetracyclines will accumulate and renal function is impaired and increase nephrotoxicity. They are also secreted in milk, and their minimum therapeutic level is 0.5 to 1 microgram per ml serum. Now, we move on to the clinical uses of tetracyclines. These are used in the treatment of mastitis, coliform salmonella enteritis, bronchopneumonia in all species, urinary tract infections, metritis, pyodermatitis, cystitis, disease like actinomycosis, actinobacilliosis, keratoconjunctivitis, brucellosis, chlamydiosis, rickettsiosis, nocardiosis, borreliosis, ehrlichiosis, hemobartonellosis, and babesiosis. This also includes anaplasmosis and other mentioned diseases in this slide. Now we know the clinical uses of tetracyclines. Now we move on to the adverse reactions and toxicity brought by the use of tetracyclines. First is we have the alteration in microflora in rumen or intestines. Following oral use leads to digestive disturbances and ruminal stasis and decrease in synthesis and availability of vitamin B and K, particularly in monogastric animals. B is we have superinfections by fungi, yeasts, and resistant bacteria may cause severe or fatal diarrhea, especially in horses, following oral or parenteral administration. C is we have tetracyclines are deposited in growing teeth and bones and should not be used in growing animals because they cause yellowish and later brownish discoloration of teeth and suppress bone growth. D is we have tetracycline should not be used with immunization programs as they cause immunosuppression. E is we have intramammary infusion of chlortetracycline is contraindicated in dry cows. And if infused, cows may fail to lactate after parturition. F is we have the intra-articular injections of tetracyclines are contraindicated. This can cause severe irritation and inflammation. G is we have if administered by rapid intravenous injection, hypotension and acute collapse may occur in cattle and horses due to chelation of blood calcium, and this can be avoided by slow infusion of the drug or pre-treatment with intravenous calcium gluconate. H is we have tetracyclines in high doses produces hepatoxicity, particularly in pregnant animals or those having renal abnormalities. I is we have all tetracyclines in high doses are potentially nephrotoxic due to the decrease in host protein synthesis and anti-anabolic effect. J is we have phototoxic dermatitis. It is common with demycyclocyline and doxycycline in man, which is rare in animals. Hypersensitivity is rare. Case we have in human ingestion of outdated tetracyclines. It produces a syndrome characterized by aminoaciduria, glycosuria, pyuria, and polydipsia due to proximal convoluted tubular damage or the Fanconi syndrome. And lastly, we have the L, the demiclocycline, which induces diuresis or ADH antagonisms. Next, in this slide, we have the precautions while using tetracyclines. It is contraindicated in pregnant, lactating, and young animals. Must be cautiously used in animals with renal and hepatic dysfunctions. Injectable tetracyclines should never be mixed with penicillin. For the dosage of tetracycline and oxytetracycline for dogs and cats should be administered 20 mg per kilogram orally at 12-hour intervals and 7 to 10 mg per kilogram a day intramuscularly or intravenously once a day. For the drug oxytetracycline for calf, foal, lamb, and pig, it should be given 10 to 20 mg per kilogram orally at 12-hour intervals. And for the horse, foal, cattle, calf, sheep, and lamb, and pig, it should be given 5 to 10 mg per kilogram intramuscularly or intravenously once a day. For the drug doxycycline, small animals should be given 5 to 10 mg per kilogram orally once a day or 5 mg per kilogram intramuscularly or intravenously once a day. Lastly, for the drug rolitetracycline for cattle, they should be given 2 mg per kilogram intravenously once a day. For the last slide, we have the withdrawal periods. For oxytetracycline, cattle and pig, 22 days, and for poultry, 5 days. In the use of oxytetracycline, a long-acting drug in cattle, it is 28 days, and for the use of chlortetracycline in cattle, it should be 10 days, and pigs 7 days. And oxytetracyclines are not to be used in lactating cows. Following my report, here we have Cyril Gonzaga for the discussion of chloramphenicol and congeners and microlide antibiotics, and lastly, lincosamide.